Hello and welcome to the latest session of Independent Sage. Over the next few fortnightly sessions, we're continuing our plan to focus on key subjects that have raised many questions over the past 3 years. In a couple of weeks, we'll have Kit Yates, Duncan Robertson, and Christina Pargall, our resident data nerds, talking about modeling and data. We'll then have Steve Reicher and Trish Green, our leading one, 2 weeks later on behavior. We've got Aris Katsarakis, Danny Ortman, Sheena Cruikshank, and Steve Griffin all talking about viruses, variants, and vaccines after that. When we've got Zubaida, Martin McKee, and Leonard all talking about vulnerability. And finally, we'll have a sort of grand finale in December where we invite back some old laggards like Dean and Pillay and Sir David King. So that's it. So if you've got any questions and you think of them when you're in bed or on the bus or in the bath, send them in to questions@independentsage.org because we'd much rather answer your questions. And if you want to come in and talk live, so much the better. We'll give you priority. Right. Today we're focusing on shocks and resilience. What's a shock? Well, it's COVID. It's an economic collapse. It's a worsening of climate change consequences. We clearly in January 2020 were not prepared, and we'd had a weak public health system getting worse for a long time. So how can we make things more resilient? And there is a bit of confusion about that. So we've got 3 fantastic experts to talk with us today. But before that, I'm going to invite our numbers nerd, Dr. Kit Yates, to give us a situation update. Over to you, Kit.
Great. Thank you so much, Anthony. Yeah, so it's lovely to be back doing this. It's been a while since I last did the numbers. So what are the headlines today? Well, the picture on prevalence is difficult to discern because we've lost so many data sources. Hospitalizations do seem to have declined in the last week after having risen for quite a long period before that. Deaths are rising as a result of those rising hospitalizations and the higher prevalence. And because we're talking about resilience, I've looked at hospital key performance indicators for England in particular, and they're not looking particularly pretty, as they haven't been for a while. So this is what we're going to try and cover today. We're going to look at cases or prevalence, hospitalizations, deaths, and key performance indicators. So here we go. So first things first, where we usually start, cases or prevalence. So we have no longer got a reliable indicator of what the prevalence is. We don't have the ONS infection survey. There were rumours that it was going to restart. I think those rumours are not true, unfortunately. So the best thing we have is daily test positivity, which is and has been a useful metric because by positivity, we count the number of positive tests and we divide by the number of tests being taken. That allows us to account for the fact that testing changes over time. So obviously, with more people taking tests, you'd expect more positive test results, even if the underlying prevalence of COVID wasn't changing. So positivity allows us to factor out that change in testing. And what you can see here, the right-hand side, is that we have been on a rise for quite a while since the summer, middle of the summer. And this week, it looks like we've just reached a short downturn. So we'll see what happens with that. But I'm hopeful that that might be a genuine peak and we might see falls from now on. Let's see what happens with that. Again, looking regionally across England, you can see it's actually a bit of a mixed picture. Some regions you're seeing rises and other regions you're seeing falls. So again, just to orientate you, the grey bars are previous weeks getting more recent as they get darker, and the orange bar is the most recent week. And you can see that, for example, in the northeast, we've got a rise in prevalence over the last week, but we've seen small falls in places like Yorkshire and Humber, West Midlands, and the east of England. So it's a bit of a mixed picture regionally. The other source of data that we have for prevalence and cases is the Zoe symptom tracker app. People register their symptoms and Zoe puts that into a model which allows them to estimate the prevalence. So what you can see up to the latest data point, which is the 10th of September, is that it looks like prevalence has been rising across the UK. Around 1.3 million people currently infected. The issue with this data is now that the last reporting date was the 10th of September, and there have been no more updates on Zoe since then. People have written to Zoe to find out why, and they've suggested that with fewer people registering their symptoms, it's becoming more and more difficult for them to accurately ascertain what the prevalence of COVID is across the population. So this may be one more data source that has gone kaput and leaving us slightly more in the gloom about what's happening. So as I say, it looks like it's rising, although this is 10 days old, and other data sources suggest we might just have peaked in cases. So we'll see what happens next week. In terms of hospitalizations, this data, this is from NHS England. This supports the idea that prevalence has peaked and is now falling. We saw a fall in the most recent week on the right-hand side here. It's a similar picture for Scotland as well, actually. Again, we've seen a rise up to relatively high levels compared to where we were earlier in the summer, and then we've seen a short fall. So long may that continue, hopefully. And this is just breaking the English data down by region. Again, pink bars are previous weeks, and the red one is the most recent week. And you can see actually we've seen falls in all of the NHS regions in the most recent week, which is good news. So hopefully this is a genuine fall in hospitalizations or hospitalization rate. Not just a blip in the data. This is just looking at occupied beds, which is doing the same sort of thing. It's slightly lagged compared to admissions, but you can see that occupied beds is also starting to come down. And the other thing that I like to look at is mechanical ventilation beds, which you can see is at historically low levels. Now, part of this is because of the nature of COVID has changed. It's not just this respiratory disease, which we knew it as at the start, or that's what we thought of it as at the start. But still, it's good to see these mechanical ventilation beds are at historically low levels of occupation, although they have risen slightly with the prevalence that we've seen rising over the last couple of months. So that's hospital situation. And then deaths is the last metric that we look at. It's usually lagged, and in this case, you can see it is indeed lagged. We can see that we have rises, a small rise for the most recent data, but this is lagged by a few weeks. And of course, deaths come sometime after infections and hospitalizations. So we can expect to see this rising for the next couple of weeks, I suspect. And this is the same picture. That was UK deaths, and this is English deaths. So you can see that it's almost exactly the same pattern. We're seeing rises, and we'll expect to see that rise into the future for the next couple of weeks. So the last thing, because we're talking about resilience today, one aspect of resilience is having a resilient health service. And so we know that the NHS took a knock because of COVID, but we also know that there are other factors which are influencing how well the NHS is doing in terms of its funding, recruitment, and so on. So I wanted to have a look at the hospital key performance indicators. Now, these came out last week on the 14th of September. They actually relate to data from August and July, so they're a bit lagged, but this is the most recent data that we have. So first, the ambulance response times. These became catastrophically bad last year. So this first chart is for C1 and C1T, the most urgent category of calls. These are life-threatening conditions like heart attacks, respiratory arrest. So C1 is an emergency vehicle of any type responding, and C1T is an emergency vehicle with the appropriate transport to get you or get the patient to hospital. And you can see the target is 7 minutes, and we haven't been anywhere near 7 minutes for a while. We're getting down to close to 8 minutes for just a response, but we're still up at above 10 minutes for a response with the appropriate transport. And we know that these response times make a real difference, which is why we have these targets in the first place. So it's not great news that we're missing them in September as we head towards winter. Similarly, this is for category 2 calls, so this includes some strokes and potential chest pain, so potentially heart attacks. You can see it got catastrophically bad. The target is 18 minutes. It was above an hour and a half last winter. It's come down, which is obviously good news, but it's still way above the target and way above where it's been historically. So this is not good news. Again, heading towards winter, I really hope we don't see the same sorts of spikes that we saw last year. So that's that's ambulance response times, which are intricately linked with A&Es, because obviously if A&Es are really full, then patients can't be discharged from ambulances and admitted into A&E, which makes ambulance response times worse. So looking at A&Es, This is the number of A&E patients who were admitted, who waited longer than 12 hours from arriving at A&E to being admitted. It's 112,000. That figure is actually probably more useful in terms of a proportion of people who were eventually admitted. 37% of people who were eventually admitted waited longer than 12 hours from arriving at hospital to being admitted. And again, we know that this time makes a difference. People waiting in A&Es, people waiting on trolleys, it's linked with worse outcomes. So this is really bad news. Similarly, again, we're seeing rises in the percentage of A&E attendances which last longer than 4 hours from arrival to admission, transfer or discharge. So this is now up at 27%. So that's over 500,000 patients in August waited longer than 4 hours from arrival to admission. And again, it's not as high as it's ever been. That was last winter, but it's still higher than almost all the time that we've been keeping metrics over the last 10 years at least. So this is bad news. And this is the same data, but plotted over time. So these are representing different years here. We've got 2019 and 20, and then 21 in brown, 22 in yellow. You can see that it's risen and was very high in 22, and then 23 we're tracking along roughly the same path as we head towards winter. So this is not very good news. Again, looking at A&Es, this is attendances greater than 12 hours from the decision to admit to admission. Okay, so once they've decided to admit someone, 5.5% of people now are waiting longer than 12 hours to actually be admitted. Again, it's not as bad as it's ever been, but it's still so much worse than it has been. Like typically you can see there's a small peak for each winter every year. But really what we care about is not how high the relative peak is, but the area under the curve, because this is the cumulative effect that this is having. And you can see that the area under the curve over the last year is way, way more than it has been over the preceding 10 years combined. And then lastly, some people just give up waiting for A&E. So 4.8% of people are leaving before treatment is completed, which must be a sort of fairly desperate situation. If you thought it was serious enough to go to A&E, then you've just given up. Last two things are testing. So looking at testing, the number of patients waiting for a test every month, we've got 1.6 million people waiting for a test at the moment. And similarly, looking at people who've waited longer than 6 weeks and people who've waited longer than 13 weeks, so that's in blue and in red respectively. We've got huge numbers of people waiting a long time just to receive a diagnostic test on the NHS. And it's the same story. Patients waiting for treatment in England, this is now as high as it's ever been. I was reporting on this last year when it was high and sort of I was incredulous at how many people were waiting. It's 7.68 million people now, which is roughly 1 in 8 people in England waiting for treatment. Not 1 in 8 patients, 1 in 8 people, 1 in 8 of our population waiting to start treatment, which is a shocking statistic. And similarly, 41% of patients, so over 3 million patients, are waiting longer than 18 weeks to start non-emergency consultant treatment. And our target for that is 8% of people, and we're 41% of people who are waiting longer than 18 weeks. So this is really bad news as well. And again, you can see it's not as bad as it's ever been, but it's still really bad compared to previous time points. And then patients waiting longer than a year to start non-emergency treatment. Again, same story. It peaked. It's come back down a little. It's now still at 5.1%. They said people are waiting. We haven't cleared those backlogs that occurred during the acute phase of the pandemic. So just to summarize where we are, it seems likely that cases have peaked at a relatively high level, but finding out what's happening with cases isn't easy. We're losing data sources. I highlighted that we might be losing Zoe at the moment. We've lost the COVID infection survey. We're really, really sparse on case data. Hospitalizations have fallen in the most recent week, so that's good news. But again, they have been rising, so that's obviously not great. And deaths are rising again as a result of those hospitalizations. And in terms of our session that's coming up, in terms of resilience, our NHS doesn't look particularly resilient at the moment. So that's where I'll leave it. I'll pass back to Anthony and I'll say thank you for listening.
Kit, thank you. That was brilliant and sobering. I mean, the data on health care is really shocking, actually. We're not shocked. That's the problem. Anyway, let's move on, and I'm sure this will resonate with our guests. So we've got three outstanding experts, and the first is Professor Steve Thomas. He's an economist. He chairs the Health Policy and Management Department at Trinity College, Dublin. He leads a big research program called Restore, and his whole interest is focused on health system resilience and reform. So, Steve, give us your thoughts on the concepts of health resilience.
Thanks, Anthony, and it's great to be here. So I'm just going to take you through a whistle-stop tour because there's so much I could talk about, but I think Kit focused us in on some very interesting data, and we'll come back to some of that now. So we are very much living in interesting times. And this was we did a survey with some health system experts through the EU in 2019 in July. It's actually 6 months before COVID. And we said, what are you worried about? What shocks and crises are you worried that will hit your health system? What keeps you awake at night? And they gave a whole range of different responses. Interestingly enough, their top worry was epidemiological shocks. Little did they know how right they were. But actually, it's interesting to note just the vast range of different shocks and crises that can actually hit your health system. And therefore, it presents the challenge of how actually do you get prepared for all that? And how do you make your system resilient to it? And that's, of course, the shocks that we know about. Then, of course, there are the other shocks that maybe the American Congress knows a bit more about than we all do, that actually come out of nowhere and we don't see. But whatever shock comes, it's going to be a profound stress test to the system. We've seen that with COVID. We saw that with austerity. Obviously, with the private nursing homes, that's a key point at which the shock reveals where your weakest link is, if you like. But at the same time, I think shocks, from all the research I've been doing, actually can be used to catalyze and improve your health system if you're smart enough. Anyway, so let's just move on. And thinking about the concept of health system resilience, what's it actually all about? Well, initially, it was very focused on kind of issues of the management of the shock, the stage 3 in this diagram here, and to do with the fact that we have so many more needs when a shock occurs, and yet the shock often undermines our ability to meet those needs. So there's a key focus on that, just how do we manage that dynamic? But actually, that's not enough because it doesn't deal with the fact that actually shocks profoundly change society. They profoundly change the health system. So we need to deal with the legacy of that. It, very much the legacy of austerity probably undermined how we dealt with COVID. So we come to this notion of the shock cycle here, from stage 1 preparedness to onset and alert to impact and management and recovery and learning. And then resilient health systems then need to be able to manage each of these stages. And I think there are quite different demands at each of these stages now. And interestingly, we did a recent review of resilience research over 20 years, and that's just shown in the bottom right bar chart. And actually, there's a lot of focus on the management of the shock, but actually very little focus on the aftermath, on the legacy of what we're left with. And that's actually what we're really looking at now in relation to COVID. What state is the health system in? There was interestingly some analysis around preparedness, but mixed results on it. Sometimes you can be prepared for the wrong shock. Sometimes preparedness can make you think that the shock isn't going to be a problem, and you become slightly blasé about it, and you don't respond quickly. So preparedness isn't always a good guarantee, although it can help in certain circumstances. Okay, now measuring resilience has always been quite a tricky thing. And we can explore some of the issues around them, perhaps in the chat later. But one useful figure, I think, relates to excess mortality, and this was a recent study presented in the Lancet here, and it looks really at over the COVID period, what was mortality like compared to what you'd normally expect it to be. So here we have some countries who actually had lower mortality. So that would be Iceland, New Zealand, Australia, and if you believe the data, China. I'm not sure I do believe that, but there goes my Chinese research grant. Ireland didn't do too badly. We had quite low excess mortality from all causes. Other countries did less well. So this isn't a bad measure because it's not just focusing on COVID. It's focusing on how the rest of the system is performing as well. And it's that in its entirety that you're wanting to look at from a resilience perspective. Not just can you meet the needs of the shock, but can you keep the show on the road? Can you keep the system going in a sustainable and accessible way? Now, we did quite well in Ireland in terms of our overall metrics, in terms of our excess mortality, in terms of our governance. We responded quite quickly, but we were left with quite strong legacy impacts that we can see here. And two in particular that I think are worth calling out, because I think they're probably common to many high-income countries. The first of all is staff turnover and burnout. We're now seeing a lot of people leaving the health system, and that's across all the different cadres, whether it's doctors, nurses, healthcare professionals. There's a lot of people leaving, and that's a cause of great concern, because at the same time that that's happening, we also have, as was highlighted by Kit, problems of access, problems of waiting lists. We also have those problems in Ireland too. We had that as a legacy of austerity. We had very high waiting lists. It came down, and then from COVID, it's gone up again, and it's very sticky. And that's partly to do with two factors. I think it's the sort of a pent-up demand. You've got your issue where people on elective care haven't been able to get in to get treatment because of COVID, and also people who are just not presenting for care and therefore delaying when they present. So we often see that from big shocks is that you often get a pent-up demand that then pushes the system, just as much after as it does before. So the need that we can take resources out of the health system at this point is very much mistaken. It needs all the more to cope with the backlog that's there. On the other hand, I would say one of the positive legacies that we find in Ireland, and we have in some other countries too, is actually that there's been much more priority and more financing placed into the healthcare system. So in Ireland, we went through the bailout, and we didn't do very well from a financing point of view. We then recovered. But then we also pushed on in terms of our health funding. And some of that wasn't just towards COVID, it was actually towards strengthening the health system. And actually, in some ways, COVID actually has revitalized the prioritization of the healthcare system in Ireland. And it's revitalized and resurrected our reform program to deliver universal healthcare. So again, it's this idea that actually shocks can make you rethink and reevaluate your healthcare system, and they can be a way of reprioritizing healthcare. Having said all that, and this is my last slide because my time is probably up. Unfortunately, it doesn't end there, because, and I love this tagline from Jaws 2, just when you thought it was safe to go back into the water, here comes another shark. Well, here comes another shock. And we have now a complex economic shock that's come on the tail end of COVID, potentially even linked to some of our economic policies in COVID. We've got a cost of living crisis, migration, the Ukraine war possibly creates it on top of that. And that's, again, it's placing extra pressure on households, and it's placing extra pressure on staff as well, who are themselves feeling quite burned out. And so we're moving into the realms of permacrisis and polycrisis. And my precise technical definitions for those are: permacrisis is basically one effing thing after another, and polycrisis is everything everywhere all at once. So you get this dynamic where it's just all coming at us, which presents quite severe challenges for how we manage our health system, particularly our health workforce, through this. And so I think on that cheery note, I will stop sharing. Thank you.
Thanks very much, Steve. That was fantastic, and a lot of food for thought, and I'm sure we'll come back to a number of this. Our next expert is Dr. Anna Sagan, or Sagan, and she's based in Kazakhstan right now. She's working for the World Health Organization in Europe. but she has also coordinated a great deal of work for WHO in Europe on health system resilience. She's affiliated to the London School of Economics and to the London School of Hygiene and Tropical Medicine. And it's a great pleasure to have you here, Anna, and we're looking forward to your thoughts on this subject.
Anthony, thanks so much for having me. Can I just confirm that you can see my screen?
Yeah,
okay, thanks so much. In my presentation today, I will draw on the shock cycle framework presented by Steve and try to highlight some of the key lessons on health systems resilience from the COVID pandemic. And I will distinguish here between absorptive, adaptive, and transformative actions taken during COVID. And I will also try to highlight the very important role of health workforce in health systems resilience. Absorbing a demand-side shock such as COVID-19 is to a large extent about responding to a surge in demand for services by drawing firstly on the resources that the health system has at the onset of the shock, so at medicines, equipment, beds, and people. And we know that there were stark differences in country resource preparedness at the beginning of the pandemic, both in terms of physical and human resources. But of course, we saw that absorptive capacity could be quickly boosted in the short term, even in the health systems with very low levels of resources at the start. So, for example, we saw that many countries managed to quickly repurpose and scale up beds and facilities and increase their workforce capacity, for example, by canceling leave, extending working hours, asking medical students or retired health professionals to come back to duty. But this is generally not a sustainable solution to acute shortages and to chronic underinvestments in workforce and health systems. And more importantly, these various resources that were drawn on during the pandemic are needed not only in the right quantities and in the right place, but also in the right combination and with the right characteristics. So, for example, workforce with the right skill mix. So what is really important for resilience of a health system is how these various things that the health system has perform in combination with each other as a system. And the figures that I showed on the previous slide cannot really tell us much about that. And one measure that can help to shed light on this combined performance of the individual health system elements, such as beds and facilities and workforce, is the treatable mortality rate, which is a metric that captures deaths that could be avoided with timely and effective healthcare. So the figure here shows that European countries that were achieving lower treatable mortality rates before the pandemic, this figure here is from 2019, which means that they had stronger performing health systems, also achieved lower excess mortality rates during COVID, which is using the same data as Steve shown in his presentation. So this implies that investment in strengthening health systems during normal times may also improve their resilience to shock during the bad times. It also shifts our attention from technical capacities that I shown on the previous slides more towards health system capabilities, which means their ability to leverage the available resources and perform more effectively. So here, adaptation is another way of managing a shock. So previously, I just spoke about the first kind of reaction, which is try to absorb with what we've got. Now, if this is exhausted, we have to try to do things differently. It's a more proactive process compared to absorption. And it can include things such as changing to the roles of health workers, for instance, by allowing different type of workers to administer COVID vaccine and things like that. It can also include things such as adopting or expanding the use of new technologies. We have seen expanded use of teleconsultations in most countries and implementing new models of care. And again, the starting point and the prior preparedness of health systems mattered in how quickly they could adapt to a shock. So, for example, countries where the roles of nurses were more advanced than in other countries before the pandemic. Countries that invested in IT infrastructure in the health facilities had an advantage and could make these adaptations more easily than some other countries. Having the right information and capacity to learn was also very important to implementing these various adaptations. And this was facilitated by things such as early investment in data, research, learning networks, and things like that. So the message here is that long-term investments that we undertake into our health systems underlie their capability not only to absorb a shock, but also to be able to adapt during a crisis. So finally, a transformative action. Sometimes a shock can result in a more profound change, as explained by Steve. And this transformation can be spurred by various things. For example, by the absorptive and adaptive measures undertaken during a crisis. So, for example, short-term absorptive measures such as postponing elective surgery are not sustainable over the long term, and they might necessitate more profound changes, for example, introducing dual pathways, as had been done in some of the Asian countries after the SARS and MERS epidemics. Some of the adaptive measures that I described, such as the increased use of teleconsultations or changes in skill mix, are examples of measures that can become now more permanent. And shocks can also expose pre-existing vulnerabilities and provide a window of opportunity to undertake or accelerate bigger reforms. For example, Thailand, after the 1997 East Asian crisis, undertook very ambitious UHC reforms. We now can see Ireland doing UHC reforms during and now during COVID. Some countries in Southeast Asia have strengthened the public health structures and response capacities after the SARS and MERS epidemics. But also, shocks can lead to less favorable transformations. So, for example, the already mentioned 2008 global financial crisis in some countries led to austerity, lower investments in public health, frozen or reduced salaries, increased user charges on households, and this has led to a weakening of the health systems and weakened their capability to respond to further shocks. And in this slide, I just wanted to once again highlight the crucial role of health workers and health systems resilience. We need not only adequate workforce, but also workforce with the right distribution of skill. However, the various response measures that were taken during the pandemic that aim to bolster and realign their workforce have not always sufficiently considered issues such as staff safety, staff burnout, and sustainability. And as Steve already mentioned, workforce well-being is a very important indicator of health system resilience. But having a sick and exhausted workforce is not a sign of health systems resilience. It's actually the opposite. It signals that the resilience is exhausted at the health system level, and health system is not able to protect its workers and relies on their individual resilience to carry out its operations during crisis. And just my final slide, I want to underline that we cannot look at resilience of our health systems in isolation from the context in which they operate. Health systems are embedded in the wider political and social ecosystems, and we have seen clearly during COVID what important roles these contexts have played. And it is impossible to fully assess the resilience of a health systems without taking into account these broader contexts. And here just showing the main publications that I have drawn on in this presentation, both of which involved Steve and Professor Martin McKee. And thanks so much. That's it from my end.
Thank you very much. And the internet worked very well. So that's great, Anna. And we're going to go straight on to our third speaker, Professor John Drury, who's an old friend and been on a couple of times before. And John is a professor of social psychology at the University of Sussex. He's a member of the Independent Sage Behavioural Science Group, and he's done some extremely interesting work over the past few years on COVID and community resilience. So over to you, John.
Yeah, thanks very much, Anthony. The question I'm going to address is, can we talk about the concept of resilience in relation to the public or the community? And the short answer to that is yes. And I'm going to talk about some of the psychology. In fact, the concept of community resilience has long been embedded in plans and preparedness for civil contingencies. But throughout the pandemic, we've seen a tension in government policy and actions in relation to this question and this concept. If you cast your minds back, sorry, I can't get my, cast your minds back to the beginning of the pandemic, an announcement was made regarding when distancing was going to be brought in, and there was a delay in when that was brought in. And part of the reason for that delay was an expectation about public fatigue, that the public would not be able to endure the privation of social distancing for a long time. Now, it wasn't only the CMO that was saying this, and this was not the only reason why there was a delay in this measure, but it was widely agreed afterwards that the delay cost many lives. I mean, even the right-wing press agreed with that. And in fact, this notion of behavioural fatigue that was mobilised at this time was a concept without an empirical basis. It was not something found in the research literature. And more importantly than that, if you looked at how the public did actually respond to the requirement to socially distance and the other health protective measures that they were asked to engage in, levels of engagement throughout 2020 and throughout most of the pandemic were high. This slide is from the UCL regular survey, and it shows across the variety of guidelines that people are asked to comply with and engage with relatively high levels of adherence. So, what's important about this is why people were doing it. Now, if you look at the psychological literature on predictors of engagement with social distancing and other protective behaviours, you find the usual predictors of efficacy. Does it work? And risk, am I in a situation of risk? But the other factor that was found to be important in adherence was the sense of this being for the public good, or this being for the good of the community, sense of solidarity, identification with my community, and other measures like that. But more than engagement with the guidelines, the period in 2020 of the early part of the pandemic also saw a massive outpouring of more proactive helping of members of the public within their communities. And this is shown in several studies. There was a survey carried out in May 2020 showing that millions of people were involved in volunteering. In fact, there was an upsurge in volunteering participation. Millions of people were involved in donating and reported helping strangers. And the rise in this early period of COVID mutual aid groups is a very good example of this, because these were new grassroots community groups that arose specifically to help people, particularly with self-isolating by doing their shopping for them. They did other things as well. They walked people's dogs, they did library runs, they looked after people's gardens, they provided information, they ran food banks. Now, those of us who study the psychology of behaviour in emergencies and disasters were not surprised to see this outpouring of solidarity at the start of the pandemic. because this is a regular occurrence across different kinds of emergencies and disasters. So in terms of the psychological process, so of course, those communities that already have strong bonds with each other, people draw upon those bonds. But the other thing that happens is emergencies and disasters can create a common experience that creates a new sense of community amongst people, sometimes people that had no previous connections. And that new sense of community motivates people to get involved with each other, to help each other, to help strangers, and also to coordinate and to act as one. But one of the things we know about these disaster communities that arise in crises is they often run out of energy, run out of resources. They don't last very long, right? There's a kind of honeymoon period, and then they tend to decline. And the shame, of course, is if you think of examples like floods on my slide there, it's just at the period where people are still needing support that spontaneous community has started to decline. So we did some work on this on mutual aid groups during the early part of the pandemic. And on the slide here, you can see a figure that charts the rise and decline of a large sample of COVID mutual aid groups against the rise and decline and rise again of COVID infections. And so in the dark line, you can see at the start of the pandemic, a very sudden rise, a massive spike in activity on the Facebook pages of a large number of COVID mutual aid groups. And you see that decline. And you see towards the end of the graph, you see the grey line shooting up again, which was the second really large wave at the end of 2020. And what you see, though, is that the mutual aid groups didn't rise up again in equivalent levels of activity to match that need. And this pattern matches the pattern seen across other spontaneous forms of disaster community and other kinds of emergencies and disasters. So the question we have to ask ourselves then is, how do we scaffold, how do we support this spontaneous community resilience that often arises in the public? There is this psychological capacity, and part of the psychology of it is this shared identity, shared sense of community amongst people. But it needs more than that. I mean, what we've learned from other disasters, and we've learned the same thing from COVID mutual aid groups when we spoke to organisers across 2020 and 2021, we learned of the material support they needed to keep going. And some of this was very basic stuff. Because these were grassroots groups, they weren't established charities, they didn't have basic things like meeting rooms, they didn't have access to storage spaces, they didn't have transport. These were the things they needed. They couldn't get bank accounts, they couldn't apply for grants, they couldn't do these things themselves. They needed other organizations, such as other voluntary groups, charities, local authorities, to help them with that. And so where that didn't happen, they find it very hard to continue. So in answer to the question then, if you go back to the individual who wants to show solidarity in their community, so what would help them? Well, an obvious answer is, in order to stay at home and self-isolate and protect your community, you need a decent sick pay in order to help you to do that, which we don't currently have. And in order to support these spontaneous mutual aid groups and other community groups, they need resources like transport, meeting spaces, and so on. But I'll leave the presentation with a final point, which is that the emphasis we might place on the spontaneous capacity of the public to respond, which is embodied in the community resilience program, and which you see at times of crisis, also has this rhetorical or discursive element, because unless you back up your rhetoric of resilience with resources, right, it's empty. It's almost like saying, let them get on with it because they've got this capacity. So resources are really, really important to scaffold that basic capacity for resilience in the public.
Unmute. Right. Thank you, John. That was brilliant. Gosh, so many questions, and we've got to move on to questions. Very quickly, Steve Griffin, co-chair. do you have any immediate thoughts about some of the huge issues raised here?
Sure. I think two, really. I mean, one sort of aspect addressed at maybe Steve and Anna, and then another at John. The first is, in terms of preparedness, it's not like the government didn't practice for this. You know, there were countless different preparedness exercises, including some specific to coronavirus emergencies, actually. And yet we saw so many of those recommendations that came to light more recently in the general public, things like stockpiling PPE and testing and tracing, being ready for that sort of thing, border quarantine controls, surveillance, etc., just were not implemented. I just wondered if you had a feeling about how much austerity and general attitudes towards preparedness from the government fed into that in terms of not seeing it through. And then, John, talking about this repeat effect without the resilience and the resources, isn't it then so damaging that we were having to go back into multiple cycles of lockdown and unlocking and lockdown and unlocking because we relaxed too soon and left it too late to come back in? So those are my 2 points from that.
Thanks.
Any quick response? Yeah.
Yeah, I mean, I think governance always trumps preparedness, because unless you employ your preparedness and utilize what you've got ready, it's not going to work. And if there's a supposition that the shock is different, or is kind of, you know, because people thought it was going to be a flu or something, so the government didn't properly kick in. I think also there's a lot of literature that looks at the impact of austerity on the workforce, on financing, on equipment, on readiness. So although you think you're prepared, perhaps when it actually comes to meeting the challenge, the resources aren't that easily deployed.
Yeah, makes sense. Thank you.
Can I just say, I mean, we were hopelessly ill prepared because we developed as early as January the 28th the wrong strategy for the wrong virus. If you read the minutes, they said this is, we're doing pandemic influenza, despite the fact that WHO was saying, close this down. All the East Asian states did it. All of them did close their epidemics down within about 6 to 7 weeks. None of them had national lockdowns, apart from Hong Kong, and none of them suffered all the ignominy and economic impacts of great long lockdowns. So it was the greatest failure of scientific advice to ministers in a generation, as Jeremy Hunt said, from the Health Select Committee. So I think, you know, and none of the European countries really did much better, to be honest. So, I mean, it is about knowing the right strategy for the right virus, as well as obviously all the other things we talked about. But I've got some questions from the public, and I want to bring them in because I want to particularly start with the resilience questions. And all of you feel free to put your hand up if you want to answer them. The first is from Suzanne Davidson about this being a notifiable disease, COVID-19. And as such, it's listed on the UK Health Security Agency's list with a reporting obligation. And she says, how can registered medical practitioners fulfill their statutory duty if there is now no sufficient testing, not even in hospitals, and therefore they can't meet their obligations, which is being undermined by the government itself? And she says, secondly, the government's breaking its own laws by apparently accepting that not every COVID case is being reported correctly. So is that another example of poor resilience because they're not following their own rules? So that was one question. And then there are a couple more about employers, but let's take that one first. Is it a notifiable disease in Ireland? Anyone know?
I don't think it is anymore. I think you're required to isolate at home now, but you don't have to present. You don't have to tell anybody.
Does anyone know about whether it remains? I mean, Suzanne believes that it is notifiable in the UK. Has that been lifted, or is it just being left to peter out, as seems to be a key element of our public health response these days?
Well, it's interesting. Most notifiable diseases, from my position as a GP, I notify what was Public Health England, presumably UK HSA. Now, if somebody presents with a notifiable disease, from fairly early on in the COVID thing, when I got a COVID test result back, it would say you do not need to notify this, because they were collecting the data. So I didn't need to notify. Whether it still counts as notifiable disease is another very interesting question, and I don't know the answer to that. Maybe others on the call do.
We need to look that up, actually, because it is, if they're breaking their own laws, that is something of some seriousness. But anyway, okay, let me go on to the next question then next two questions about another aspect of community, actually, are employers. So Les Spears has written in to say, I recently became ill, tested positive for COVID. On contacting my employer with a photo of my positive test, I was told I don't need to test anymore. My sickness would be recorded as flu-like symptoms. I can come to work as soon as I feel well enough. Les says that clearly isn't correct. So could you clarify the correct advice in such circumstances? Helen?
It's really difficult, isn't it? Because the suggestion that you should stay at home until you're not infectious to anybody else seems to have gone out of the window now. And it's very difficult for employers. I mean, even in healthcare, we're not supposed to be asking our colleagues to test, and we're supposed to be telling them to come back after, as soon as they're well. There are, I think, some minor exceptions if you actually work in the oncology department or with people who are persistently immunosuppressed, but the kind of it seems to have gone out of the window, the idea that we should be preventing the spread of this illness, which is very odd. But I think it's hard for people themselves, for employees. They may feel very rightly that they've got an obligation to not let their colleagues get ill, and not let their customers or patients or whoever else get ill. But yet there are many employees who have quite a punitive approach towards sickness absence. And so if they take some days off when they know they've still got COVID but are not feeling particularly unwell, I think it's quite a difficult decision for people to take.
So there's the end of infection control, the end of public health, basically. So
pretty much.
Stephen Reicher, Professor Stephen Reicher, sorry.
Yeah. So, I mean, in many ways, this is a theme that's been running throughout the pandemic. I mean, last week I spoke about the way in which the government did virtually nothing to ensure that workplaces were safe. In the first year of the pandemic, 125,000 individuals were fined. 78 employers were notified on practice, and nobody was prosecuted. So very little has been done. My understanding now is, yes, the advice is appalling advice, which does allow, in effect, people to come back to work without testing, and certainly doesn't stop them coming back to work if they are unwell. In 2022, the TUC did surveys showing that 1/10 of workers had been pressured to come back to work when they were ill, and that 1/10 of workers had been pressured to work alongside somebody who was ill. So really large proportions of people. And I think we need to look at this at various levels. I mean, first of all, of course, we need to pressurize the government. We need to pressurize them, as John said, first of all, to have decent sick pay. I mean, that's, as a public health measure, it seems to me that's the most important single thing we could do, and certainly should be put on the agenda for the next general election. We need to make sure that adequate funds are put into the Health and Safety Executive, because one of the reasons why there are no enforcements is that their funding has been absolutely slashed, so they weren't able to investigate. But also there are good employers out there, and employers can do better than the government. And I would remind people of the COVID Pledge campaign, which is precisely around this. One of its centre points is for businesses to pledge that they will support people to stay at home when they are unwell. And it does seem to me that we can campaign to make clear that it is advantageous for businesses to do that, because people will be more confident to shop in shops when there aren't sick workers. They'll be more confident to go to restaurants if their waiters aren't sick. So I do think this is an area where we can do some work where, well, I mean, we can't rely on the government for much, but certainly on this, we can't rely on them. But I think we can build an alliance with progressive employers, and many hundreds have signed up to the COVID pledge, and many more should do so.
Okay, thanks very much, Steve. We could have talked about another question about clean air, but I'm going to leave that for another day because we'll come back to that. I've got two questions on vaccines, which I'd like to get views from Aris, Sheena, and Steve about, because they're quite important. The two questions are, one from Steve Mantle. I've read that it may be better to delay a COVID booster to later this year rather than taking it immediately, on the grounds that any COVID wave is likely to be higher in January, by which time any extra COVID immunity boost may be waning. Is this correct? If so, would the same apply to influenza vaccine? So the first question is all about delaying a vaccine. And the second is about having a new one or an old one. It appears Scotland is switching to the new XXB vaccine from the 25th of September, which is obviously good news. But please, could someone find out if England and Wales plan to follow suit? If Scotland has access to the latest XXB vaccines, then there's no reason why England and Wales shouldn't also be using them. Also, I understand the point that anything is better than nothing. Personally, I would much rather have the most up-to-date vaccine available over one that's already out of date. Right, anyone of our vaccine experts on delaying generally or new versus old? Oh, they've all gone quiet over there. Aris, anything? You're muted.
Yeah, okay. So I mean I would advise people to go for whatever they're eligible for as soon as they're eligible for it. I think there are important questions around nationwide policy and making the best available booster as widely available to as many individuals as possible. And you know, yes, I would rather have an updated booster than an old one. But unfortunately, it's not really possible for individuals to sort of game their choice of vaccine in a way so as to optimize it. And I think on balance, it will always be a better option to take whatever is available to you as soon as it is available to you. That's the sort of short answer.
Great, that's interesting. I mean, does anyone, Sheena, I don't know if you have any thoughts on this, and also why is it that, you know, in Scotland you can get the new vaccine, but you can't in England and Wales? What's all that about?
Well, I think so normally when we're looking at flu, we tend to look at what happens over in Australia, and they've had quite an early and quite a severe flu season this year, is my understanding. So if we follow the same pattern, it'd be predicted to also be early. And if that is true, then I think waiting until January would be a big mistake. You're going to get exactly the same vaccine then. So I definitely think you should do it then. COVID has not settled into any kind of seasonal pattern, as we've seen from Kit's data. So I think it would just be a gamble, and it's not a gamble, as Aris just said. I think you should take what you can get. There's been a lot of discussion about the types of vaccine on offer, and there was, you know, some discussion quite early on this year about sort of switching away from vaccines that included the Wuhan ancestral strain of COVID, and trying to include vaccines that were more based around XBB. The UK, to my knowledge, had not secured supplies of that. So I haven't seen anything that tells me that Scotland has managed to secure supplies. We very, very recently approved it. We may have in Scotland, and if that's the case, then that's fantastic. But as the COVID vaccine campaign started several weeks ago in Scotland, quite a few people will have been getting the existing vaccines, and they will give you some protection. They will help, particularly if you're clinically vulnerable. We know people's antibodies fall a lot. So I think it's so important to take what you can get.
And if it gets you now, if you got it now, it protects you into January pretty well, doesn't it?
It should do, yes. Your antibody levels should stay up, so you should get that kind of nice pattern of protection. And you don't want to ruin Christmas by getting COVID or flu.
Thank you. I must go and get my vaccine. God, we need more time, don't we? There's so many interesting things that have come up today. There was one final question where Anne Webster wrote in to say, any comment on the study that says face masks decrease cognitive function and increase reaction time, advertised in the outlet Daily Skeptic? Well, don't read the Daily Skeptic. I went in and read it. It's a load of nonsense. They had no comparison group. They had 40-odd nurses who they gave a teaching session for 5 hours. They were all wearing masks. At the end, they said, oh, they're tired and their brains don't work. And they didn't have a comparison group that didn't wear masks. I mean, my students fall asleep after an hour. So, and their brains did try. So this was nonsense. So just don't read the Daily Skeptic. Right. Finally, thank you so much to all your questions. Remember, keep sending them in, questions@independentsage.org. Thank you hugely to our experts. We could have talked for another half an hour about resilience at least. The next one's on modeling and data with our troublemakers, Kit Yates, Christina Barlow and Duncan Robertson. That'd be really lively. Send them in. See you in 2 weeks. Till then, take care and keep safe.
Bye.
Cheers, everyone.